Second half of this discussion is on similar issues, but from the state and local perspectives, which in our country matters. Much of health policy is different at the federal level, at the state level, and the local level, as we all saw over the last several years, and it was very evident. We have another stellar lineup of panelists, and just briefly on each of them, Dr. Barbara Ferrer, Director of the LA County Department of Public Health, and has led that for the last several years during the pandemic, which has probably felt like an entire lifetime, I am sure, as we talked about briefly some of the travails that you had gone through. And thank you for your service there as a fellow Los Angelian. Dr. Anthony Iton, Senior Vice President of the California Endowment and a lecturer in Health Policy and Management of UC Berkeley School of Public Health. Dr. Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement at Johns Hopkins, Bloomberg School of Public Health. Previously Health Secretary of Maryland and Health Commissioner in my birthtown, Baltimore, Maryland. Claudia Williams, founding CEO of Manifest MedEx, the largest nonprofit health data network in California, which looks at 32 million residents of the state with a particular focus on health equity, and who had served before that in the Obama White House on innovation and technology in health. All right, so Dr. Sharfstein, you're giving me like a scared look here.
Maddie.
You had some clear successes in Maryland, and Maryland has been at the vanguard of many of the things in public health on data side, but particularly using electronic health records for public health purposes through a health information exchange. Walk us through what you accomplished, and I think just as importantly, how that data is used to improve health outcomes. Give us some flavor for what it was about.
Sure. When I became the health secretary in Maryland, we had about half or 2/3 of the hospitals connected for data, and most of the use cases were about clinical lookups, like if you're in the emergency room, did you have a CT scan somewhere else? And it had been jump-started by some of the hospital systems, and we can get back to that. It had been supported by the high-tech funding, and it was kind of running out of steam. And the leaders of that system came and said, we envision this as a clinical program, but we don't see where the money can come from to really build it out for the whole state. And what we worked on together was, I'll get the governor's into this. The governor will visit every CEO that hasn't signed up and tell them they need to. We will get everybody on board. We will get you funding, particularly through Medicaid and other ways. We'll even get a provision in the law that designates you as the state's health information exchange, so we don't have to go through any procurement processes to give you funds to do things that you can do. But in exchange for that, you're really a public health utility, not just a clinical program. You have to double the size of your board and put some public people on it, and you need to have a provision in your bylaws that says the health secretary can wipe out the board if it's not acting in the best interest of Maryland, because we're really going all in, because this is about the health of the people of the state, And they went for it. They doubled the size of their board. We got the law. We got a whole bunch of money for them. And as they were building out their clinical systems, they were building public health, things. Just to start, it was a map. They know where every hospitalization is. They were matching all the data. And health officers could get maps of asthma or COPD for their jurisdictions. We were then, they were building some very interesting healthcare applications which have population health implications, but I'll stick to the more public health things. Something that they did in Maryland for Baltimore City was whenever an older adult fell, the information was mapped and went to the city health department, and they could actually see in real time, essentially, people who fell, went to the ER. Sorry about that. Thank you.
See, data sharing right here. Yeah. This is great.
Because typically if you think just clinically, you think, well, somebody has fallen and...
it was inoperable, unfortunately.
I don't know if this is on. Is this on?
Yeah.
Okay. You can think, okay, we're going to help an individual person. And I'm in favor of putting social determinants into the medical record to help that individual person. But from a public health perspective, the huge opportunity is if you think about how to improve the environment, how to improve the community. So you see in this one area, all these older adults falling. What's going on? Turned out the supermarket moved, in one place. And so they were able to work with community organizations, figure out how to get food to the people who are living in the older adult housing. That's something that is going to be very hard to figure out one patient at a time. And I'll just give one other example, which the same system has built out starting in the District of Columbia, because the umbrella now of this system is over a number of different states. And that is around absenteeism. And the idea that school systems can share absenteeism data, the system can bring it in just like it's a lab value, and you can look at it on a map. Absenteeism isn't just about what's wrong with this kid, what's wrong with this family. It's about what can support a particular community, how do we help do that, but also share it across to pediatricians so they really understand what's going on with kids. I'm a pediatrician. It matters a lot how kids are doing in school. And then they can be helpful to the family and work with the school, with the family, with others to help them succeed. So I could go on. There's a lead poisoning use case. There's people people who are with HIV but out of treatment, a flag for community health workers to go out and help them if they appear in the system. Many, many different things once you have that platform to use. And it was really a deal, but with us and the Health Information Exchange. But underlying that deal, I'll just say this, was the fact that Maryland's hospitals were excited to do this. They were completely supportive, and that's because Maryland pays hospitals differently than any other state in the country. I don't think that's irrelevant. I think in a sense we're the exception that proves the rule. I don't think the reason that there's been so much failure is entirely just because people haven't figured out how to craft the pitch just the right way. I think that it has to do with the incentives that are there, the politics that are there, what problems people really want to solve. Maryland, we were dealt a different set of cards. We have a unusual healthcare system where hospitals really are incentivized to work together, because if people in Maryland are healthier, they all do better. And that created the preconditions that made it possible to have a health information exchange as effective as CRISP.
That's great. Claudia, does that compare with your experience here in the great state of California? And where has Manifest MedEx succeeded, and where have you run into obstacles in that regard?
Sure. And just to clarify, I've been on a lovely sabbatical since June. I left MX in June. And what I'll do then is to kind of extrapolate up to the landscape of health information exchanges across the country. So I think we've heard already that COVID revealed problems that anyone in public health knew existed, which was incomplete data, lagged data, no context for the data. We didn't know if a person with COVID had pre-existing conditions, and no feedback loop to the folks that need to know about something happening. These are problems people in public health have been working a long time on, but lacked the infrastructure and the funding really to do it. And I think one of the key components that's needed is access to a large realm, some personally identifiable, some de-identified data that isn't in the jurisdiction of public health. It's not a reportable ELR, right? And we're never going to be able to reach our bigger goals of health improvement unless there's access to data that allows us to have insights before things happen and to look at across the whole population. So what this means is public health needs access to a lot more data. I think the technology, what you do with that data, machine learning, AI, all those things, we have lots of capabilities, but I think if you don't have the data to feed into those machines, you're never going to get the right results. At the same time, we have almost zero appetite for more data collection at the federal level. I wish that wasn't the case, but when you look at the hospital's responses to a new data collection effort halfway through COVID, it felt like a big distraction. It was really hard. A lot of stuff was being coded on the back end. So where that leaves us is, how do we access important insights and data without a massive new data collection effort, using the existing technology and data we have? And I think many, many states turn to their health information exchange partners as the answer to that question during COVID. And I just want to highlight some of the specific use cases that we saw and talk about how many states were doing those things. One use case was actually looking at the individual health record of a patient. This would be relevant for like a case investigation. But we don't, like you have a case, you don't really know what the background is. You don't know what the up-to-date contact information is. You don't know chronic care conditions. And so I have it here. 38 states partnered with their HIEs to give public health access to individual health records. And remember, and maybe this is a slight modification of what David Feinberg said, in the case of MX, we would take records from thousands of sources and parse them and integrate them into a single record. These were not PDFs. So we had lab results from multiple EHR systems, from claims. We had direct feeds of labs from Quest and LabCorp. We had the COVID data coming in as well. So one is individual health records. Second, pushing data back so that a PCP actually knows that his patient might have gotten a COVID vaccination or gotten a COVID positive test. Up to now, this was sometimes done on a query basis, but often the data weren't even there, and a busy clinician is not going to go query every time they see a patient. So an ADT alert, an alert back to the doctor saying, hey, heads up, your patient just tested positive. 36 states partnered with their HIEs to deliver those kinds of results. Enhancing data, we saw that lab results often came in with incomplete race information, contact information, and almost always no background, clinical background of the patient. We saw 23 states doing that with their partners. And the other two I would mention is actually performing core public health functions. So in the case of MX, my old organization, they are running the COVID lab system for the state now. They are receiving all the COVID data. They are processing it. In Indiana, the HIE is actually the official designated party to identify a COVID case. All the lab results come through them. We have other examples where they're running syndromic, I think maybe I don't know if in Maryland. So great examples. What they found at the end of this last period is that they needed more formalization, as Josh was saying. So we have multiple states now that are looking to formally designate the HIE as a public health data utility, looking to access and leverage federal funding, mandating bidirectional exchange between the HIE and the state, and also often mandating greater data sharing. In the example of LA, we have a bunch of hospitals that are not yet sharing data with the two HIEs operating in the county. So I think there's a wonderful model now for how to extend those examples we saw in COVID. And there's actually legislative language now circulating from Civitas to ask for federal funding that could also serve the role of aligning these state level efforts to actually create data that could be usable by the feds. So sorry for
Oh, no, it's great.
a complete.
So, Barbara, you led the health response of the second largest city in the country, and I'm sure it was very, very easy to collect data, to use it, to have structured data to make decisions. Tell us a little bit about that beautiful story of data in LA County.
Yeah, I think thanks for the question, and thanks for inviting me. I would say if you're on the ground, and we serve the county, our health department. We're actually the county's health department. That's over 10 million people. 4,000 square miles? It's huge. There are four basic needs for data that we had, and in all of them, you can imagine the challenges. The first is, and everybody was paying attention to this data, who's getting sick, who's getting vaccinated, who's getting therapeutics, who gets tested, where are we having outbreaks, by sector, by geography, who's affected by those outbreaks, what is the composition of the workers who are getting infected, what does it look like in their neighborhoods where they're living, because transmission is going to happen when there are more exposures. There are going to be more exposures in crowded situations. So we needed that data, the data on where do we have high density, where do we have overcrowded housing. And that data exists, but you have to put it together to use it. And everyone can understand that. When we think about, some people just said, well, you just needed to know that people were getting hospitalized. No, you want to know who's getting hospitalized. Do they have comorbidities? Have they been vaccinated? Have they been boosted? Have they been boosted twice? Have they been boosted 3 times? What's their race and their ethnicity? What's their age group? Because that data is not useful for us unless it helps us do our programming and provide services. It's not, there's a lot of interest in surveillance to understand what's going on, but for us at the local level, that data only makes sense if we can then use it to help make sure that we're addressing disproportionality and that we're keeping people alive, which is, what this pandemic ended up being about. 35,000 people lost their lives here in LA County. So, we know what the job was. So getting that data so that we could actually use it was, of course, a big task. The second thing for us is how well do these interventions work? Do the vaccines work? What do we know about people who are vaccinated versus people who aren't vaccinated? What do we know about people who are vaccinated and boosted versus those just vaccinated or versus those unvaccinated? And what's the relationship between getting vaccinated and your race or where you live? In LA County, if you're vaccinated and you live in a community with high poverty, you are more likely to be hospitalized and die than a person who lives in a wealthy community that's not vaccinated. We need that information. But in the absence of telling that story, the information is less useful. We also needed to know what differences are our interventions making. We set up telehealth. Who's getting telehealth? Does it work? Do the people who call us actually end up getting their medicine? Do they end up taking their medicine? How do you create some kind of feedback loop? We wanted to know, we have mobile vaccine teams. We offer about 600, 700 mobile teams a week. Does that make a difference? Who's more likely to use a mobile team and come to one of those sites than go to the pharmacy? And where were the mobile teams most effective? We have huge sort of areas in LA County that are health deserts, medical deserts, don't have a lot of health care. So was it working? Did it make any difference over time? And the last thing that I'm going to say the hardest pieces of information to get is what do workers and residents need and think? What is the way that we're going to really understand what people's experiences are during this pandemic that allows us, again, to do a better job at services? So those are 4 areas, and in all areas we were challenged. I think the place we do the worst is in that last area. Almost as if we don't care, but we do. But we, when you hear people talk about data, even all of us, we will talk about interoperability, we will talk about the data sets that we have talking to each other, but the data that we really need to become trusted people in our communities is data about how people feel and what is it that they think they need and how can we be helpful.
That's great. And then, Tony, you collected data or looked at data at a highly local level, neighborhoods, even individual blocks. What does that tell us? I mean, what's the role of getting so fine-grained in looking at data?
Yeah, and thanks for having me today. It's a pleasure to be up here with these guys. I know them a long time. Even Claudia, known for a while. And there's nothing I like more than being in the company of local public health people because I think that's
Tony is a local public health
salt of the earth.
It's not for the moment.
Yeah, so I started this work because I actually went to medical school in Baltimore and saw conditions on the ground that just didn't make any sense to me. I didn't understand how people could be healthy in the context of East Baltimore, which was immediately adjacent to Johns Hopkins Medical School. And became convinced that there had to be a way of studying how those conditions were creating or adversely affecting the health of people who were navigating those streets on a day-to-day basis. And so, when I became Alameda County's health officer, I was excited because you're the registrar of all births and deaths in the county. So you get these databases, you have these certificates, you run vital statistics. And every death certificate needs the health officer's signature before it can be finalized. So you can control the quality of data going into those death certificates if you take it seriously enough. 10,000 deaths a year in Alameda County, 20,000 births. And we wanted to look at patterns of death. And every death certificate tells you what somebody died of, their race, ethnicity, where they lived, and their age. And so we could actually paint a story of death in Alameda County about how it occurred. And we did that. We published maps at the census tract level showing how long somebody could expect to live, and started talking about, your zip code matters more than your genetic code when it comes to your health. And it got a lot of attention, ended up on the front page of a lot of newspapers. We went to Baltimore, we did the same thing. We did it in a number of different cities. And, to follow that up, when we saw these 30-year life expectancy differences across neighborhoods in the same city, we couldn't explain it with the typical explanations in health, which were genetics, access to health care, and behaviors. They didn't explain any of these patterns. In fact, they worked in the opposite way, if anything. Mm-hmm. And so we said, well, we need to know more about what's happening in these socio-ecological contexts. So we went to the hospitals and we said, we want to get hospital discharge data. In California, you have an organization it used to be called OSHPD, it's now called HCAI, that actually would publish, with a lag, hospital discharge data sets at the zip code level. And when we looked at that data, zip code was kind of useless to us because it merged all of these different socio-ecological contexts. And so it basically washed out all of the differences. So we wanted to get down to the census tract block group, that granularity, because we wanted to understand, and I think this is the point Barbara is making, and Josh in some ways too, local public health is where the intervention happens. It's where the rubber meets the road. And the point of this data is to do something about it, not just to look at it and publish it, and it's to actually try to design interventions. And so the people that are doing the interventions need the most granular data to make the intervention as accurate and appropriate as possible. So we went to the hospitals and we said, can we have this data down to the address level, because we want to actually use it. And meanwhile, we're guarding very sensitive data at the public health department. We've got HIV, we've got STDs, we've got a whole host of stuff. And the hospitals were like, no, we don't trust you. We don't trust you to handle that data. So, I don't like no for an answer. So we went to the legislature and we wrote a bill. And we basically, in California, HIPAA doesn't govern medical records privacy. There's actually a California Civil Code section which basically works in almost the opposite way. It says, who can hospitals release data to? And then there's an enumerated list of entities to whom have access to that data. And public health was not on that list. So the hospitals could very easily say, look, screw HIPAA. HIPAA's got this huge exemption for public health. But HIPAA didn't apply in this situation because the hospitals followed California Civil Code. So we went to change California Civil Code. And we did that. We added public health to that list after a big fight. And I could tell you crazy stories about this. You have to go, in the legislature, you have to go to the health committee. To get it out of the health committee, you have to at first go to the rules committee and then, get assigned committees. You get to the health committee. We got it out of the health committee, but then you have to go to judiciary committee. And judiciary is where all the lawyers hang out, the ACLU and all these folks.
Lawyers are the coolest people ever.
And I'm a lawyer. And so I don't like them. And so the Judiciary Committee, the ACLU is there, and they're like, we don't know what public health is. We don't care what public health is. We care about privacy, and we don't want everybody getting access to this information. So it was a huge fight at the Judiciary Committee to get public health access to this protected medical information, which we finally won after a lot of battle scars. But it was sort of indicative of sort of how little leverage public health has for something basic like that, where we were trying to characterize the socio-ecological environments beyond the zip code to get down to these neighborhoods where we were seeing 30-year life expectancy differences. So that's why public health needs this localized, granular data.
It's a great story, and I think a lot of lessons there for all of us about that. So as we go to this lightning round, quick sentence from each of you on, what is the most important step we can take at a local, state, or national level in a public, private, or philanthropic sector, so very broad here, but one thing we can take to make health data ecosystems stronger across the states. What is one thing we can do very quickly, and starting with the health commissioner of the greatest city in the country?
So, sorry.
Nice try.
I think one thing that would probably help us the most is we're going to need a lot of resources. So I'm going to say, like, this work cannot happen without resources, and it's going to need to be sustained over a long period of time. We don't need the 1 or 2 year
Got
ARPA
it.
money. I mean, that's going to help, but that's not the
So
solution.
long-term financial commitment
Long-term
on the
financial
federal level.
Federal level, state level, and local
Got
level.
it.
We got to have the money. Can't
Got
do
it.
this without it.
Second greatest city in the country.
I would say that we have to prioritize the actual public health outcomes that we have in this country. That 1 million people died of COVID, 35,000 in Los Angeles, the rest all over the country, that we are falling behind in life expectancy. We had a 2.8-year drop. If we prioritize those things, it leads naturally to being able to do a lot of different things, including sharing data better, to be successful. This is not just about the patient encounter. It's
Got it.
about empowering people who can work with their communities to change the environments that are driving the bad health outcomes.
So an optimization parameter around public health outcomes. Claudia.
I think states need to build data infrastructure that's usable not just by public health, but also by research, by clinical folks. And it's interesting, yesterday was the deadline for all providers and plans in California to sign a new data sharing agreement that would require that kind of data sharing. So I think it's a mistake to put this on the back of public health. Public health should access the kind of infrastructure we need for all of these social goals, but to ask them to spend their pennies and dollars on this alone, I think is a big mistake. So I'm not like 100% optimistic about the state policy. I have a lot of questions about it, but I think it's a move in the right direction to say this is a public good. We need to invest in it as a public good. We need to align all of our policy levers, and public health needs to benefit from that.
Tony.
Yeah, I was impressed by Josh's story about the governor of Maryland, and Julie said earlier, which is very true, we don't have a national healthcare system. We have a federal healthcare system, so we have a federation of 50 states, and that's baked into sort of the relative distribution of power, the ability to make decisions. The feds can't, or the national government can't make decisions that the feds have to follow, and that's problematic. So the leadership for this has to come at the state level, and I think that there are regions within the country that can come together in consortia to make this happen, using the Maryland model, using some of the other models that have been promulgated, but we keep waiting for Godot, which is this federal kind of, magical leader that's going to make this all happen, and it's not happening. This is the same conversation that I was involved in 20 years ago, and it's still not happening. So the states have to lead.
So to end this, to get normative behavior change, especially in the data space, we need leadership. And we thank you all for your leadership, as you've shown today. And the hope is we can begin something to actually find Godot. Thank you.
Excellent. Well